The choice of selection of antimicrobial agent in treating diseases is based upon the infecting organism, patient, and the drug. Successful chemotherapy requires a precise diagnosis and it may not always be possible for veterinary field. So under the microorganism-related factors, these following factors influence the choice to determine the antimicrobial agent. First is a choice based on clinical diagnosis of an infectious disease. To determine the pathogenic organism, preliminary clinical diagnosis be made first in order to determine the choice of antimicrobial agent since neither the pathogenic organism nor its sensitivity are varied. Second is a choice based on microbiological culture and sensitivity tests. In this case, neither the type of infecting pathogen nor its sensitivity can be predicted. In such cases, isolation, identification, and characterization of the causative agent and minimum inhibitory concentration should be assessed. So, the minimum inhibitory concentration is the lowest concentration of antimicrobial agent that inhibit the growth of bacterium after 18 to 24 hours of incubation in vitro. However, under the field conditions, it may not always be possible to ascertain the above consideration, and the situation may be as follows. When bacteriological lab facility is not available, in such case, a broad-spectrum antimicrobial agent or a combination of antibiotics should be administered to shield or to cover all likely bacterial pathogen. Second, when bacteriological lab facilities are available but treatment cannot be delayed. In this situation, specimens should be sent first for biological examination and treatment should begin as in if adequate response is not displayed. Then antimicrobial agent is replaced later as to the result of bacteriological findings. Third, bacteriological facility is available and treatment can be delayed for some times. In such situation, it is better to wait for microbiological culture and sensitivity report before therapy based on the microbiological findings.
Second, we have the animal-related factors. The choice of selection of an AMA in treating an infectious disease is based upon multiple factors, and one of those is the infected patient. So the first animal-related factor is the age, which determines the pharmacokinetic properties of the drug. This is evident in tetracyclines, which are contraindicated in young animals as they cause discoloration and weakening of teeth and bones. In addition, newborns cannot metabolize and excrete chloramphenicol because of a deficiency of a metabolizing enzyme. Likewise, aminoglycosides are excreted slowly in old animals. The reason for this is that they have poor renal function, therefore full dose of drug may cause toxicity. Moving on, another factor that must be considered in choosing an AMA is the functional capacity of the kidney and liver. So if these organs are defective, AMAs with low margin of safety such as aminoglycosides, tetracyclines, cephaloridine, cephalothin, nalidixic acid, and amphotericin B should not be administered in the presence of renal dysfunction. Similarly, drugs like erythromycin, rifampin, chloramphenicol should not also be administered in patients with liver diseases. Next factor is the host defense status. The integrity of host defense plays an important and critical role in the final eradication of the pathogens, particularly when a bacteriostatic drug is used. So bacteriostatic drugs are less effective in very young, very old, and debilitated animals because of poor or impaired host defense. But immunocompetent patients or patients with normal defense status, the said drug can cure an infection. And since bacteriostatic drug can be administered in animals with impaired defense status, bactericidal drugs are given instead. Pregnancy and lactation. So during pregnancy, particularly during the first trimester period of organosynthesis, it is better to avoid all AMAs unless it is very much essential, because this may cause abnormality in the fetus. So drugs like tetracyclines, fluoroquinolones, or aminoglycosides are cautiously given to pregnant animals as they cause teratogenicity. In contrary, penicillin, erythromycin, and some cephalosporin can be safely given in pregnant animals. On the other hand, chloramphenicol, ivermectin, and many other antibiotics and antihelmintic cannot be given to animals producing milk for human consumption because of possible human health hazard due to presence of residues in milk. Still under the animal-related factor is the drug allergy and idiosyncrasy. If there is any history of allergy of an animal to an AMA, then it should not be given in that animal. But it is also important to note that antibiotics, especially penicillin, can cause severe anaphylactic reactions not just in man, but also in animals sometimes. Moreover, aminoglycoside, erythromycin, and sulfonamides are often associated with allergic reactions and therefore should not be given in allergic patients. So the following are the last three animal-related factors that should be considered in selecting an AMA. The presence of blood, CSF, and tissue debris. So the presence of pus, blood, cerebrospinal fluid, and tissue breakdown products interferes with the efficacy of sulfonamides, nitrofurands, and aminoglycosamides, whereas these factors do not affect the efficacy of penicillin. Location of infection. So the location of infection determines the choice of AMA and route of administration. This is definitely considered in the presence of infection behind barrier and conditions such as meningitis and abscess. Lastly, the effects of AMAs on intestinal flora. Ruminants are highly dependent on the integrity of the ruminal microflora, and thus, oral administration of broad-spectrum AMAs affects the normal flora and leaving the field free for growth and multiplication of pathogenic yeast and fungi, which often results in acute diarrhea. Last, we have the drug-related factors. So important considerations when prescribing antimicrobial therapy include understanding drug characteristics that are peculiar to antimicrobial agents, such as their pharmacokinetics and efficacy at the site of infection, as well as recognizing the adverse effects of these AMAs on the host. So the first drug-related factor involved in choosing an antimicrobial agent is the sensitivity of the organism to AMA. So an AMA to which organism shows highest sensitivity is selected. Next is the type of antibacterial activity. Bactericidal AMA is preferred over bacteriostatic in patients with impaired resistance, in serious life-threatening infections, and when the infections are behind the barriers. Another one is the cost of AMA. A less costly AMA is generally preferred to expensive one, without compromising the efficacy. Pharmacokinetic properties. As mentioned earlier, the pharmacokinetic properties of the drugs are also an important factor in prescribing an antimicrobial agent. So drugs which are degraded and not absorbed orally are given parenterally. Examples of this are penicillin G, which is destroyed by gastric acid, aminoglycosides, which is not absorbed if administered orally, and chloramphenicol in ruminants, which is degraded by ruminal flora. On the other hand, in treating meningitis, drugs that can pass through BBB or blood-brain barrier are preferred. So drugs like aminoglycosides cannot pass through the blood-brain barrier and are therefore ineffective in bacterial meningitis, whereas sulfadiazine, chloramphenicol, cefotaxime, and rifampin can pass through BBB and attain high concentration in CSF and the preferred drug in meningitis. Dose of AMA. So the dose of antimicrobial should be adequate enough for the drug to attain plasma concentrations above MIC. And at the start of therapy, leading, loading, or printing dose is administered to animals to produce effective MAC. Pulse dose follows, which is done by repeating dose intermittently at specified intervals for required duration. The pulse dose may be lesser or equal to the initial dose depending on the AMA. Route of administration. The effective plasma concentration of AMA and their subsequent maintenance depends upon the route administration of the drugs. IV or intravenous route is generally preferred in life-threatening infections. Oral antimicrobial therapy is preferred in monogastric animals and young ruminants, but not advisable in adult ruminants except for enteric infections. Moving on to the antibacterial spectrum of AMA. So narrow-spectrum AMA should be used if the nature of the pathogen is characterized, to selectively inhibit pathogenic organisms only. But if no guess can be made about the nature of the organism, then broad-spectrum AMA should be used to cover all likely pathogens. The last selection factor is the toxicity. If a number of AMAs having similar efficacy can be used for the treatment of an infection, the least toxic is preferred. This is the reason why penicillin, cephalosporin, and erythromycin are preferred over aminoglycosides, tetracyclines, chloramphenicol, and vancomycin. The complications of antimicrobial therapy. The first possible complication is the allergic reactions. All AMAs, as we know, are foreign to the body and are therefore capable of producing hypersensitivity reactions, and this may be in the form of mild skin rashes or a severe anaphylaxis. So the most common offenders are sulfonamides, penicillins, aminoglycosides, and cephalosporin. Next is the microbial drug resistance. So microorganisms sometimes develop resistance or insensitiveness to AMA. Example of this is staphylococcal resistance to penicillin G, as well as enterococci to streptomycin. Moving on, we also have vitamin deficiencies. So vitamin B and K are synthesized in the gastrointestinal tract of man and animals, and the use of AMA interferes with normal intestinal microflora, particularly in herbivores, where vitamins are synthesized and which often results to vitamin deficiencies. Another complication that could possibly arise during an antimicrobial therapy is superinfection. When we say superinfection, it is the development of a new infection in the patient due to the use of AMA chemotherapy. Commonly seen in intestine, respiratory, and urogenital tract, superinfection develops when broad-spectrum antibiotics such as tetracycline, chloramphenicol, or combinations of AMAs are used. It can be avoided by using narrow-spectrum antibiotic whenever possible and by preventing indiscriminate use of antibiotics. Last, we have toxicity. So tetracyclines, erythromycin, and chloramphenicol are irritants and may cause pain and abscess formation on IM injection or thrombophlebitis on IV injection. However, cephalosporin and penicillin are least toxic due